natural history of disease actually came from public health and epidemiology. You might see it in some more general pathology books and clinical books, but it's becoming rarer and rarer to see this in other fields. Now the question is, how come you're seeing it in a family medicine lecture that talks about the biopsychosocial approach to illness? Well, first of all, let me describe to you how it's usually presented in a more general public health or epidemiology textbook. We'll just approach it in a very simple manner. Public health, well, we're dealing with health matters that affects the public or the community at large, and the idea is to try to keep people healthy and try to minimize the disease and things that would decrease the health status or the quality of health of communities or populations. So how do you do that? How do you approach it in a very structured or scientific manner? Well, you need information, and that's where epidemiology comes in. Epidemiology is a field, it's a study to get the distribution, to determine the distribution, determinants of health-related events or diseases in specific populations. So like if you have a group of people, you want to find out health-related states or events or diseases, how many people have it, the distribution curve, or the things that cause it, or the determinants, the factors that contribute to it. And then that's pretty much what epidemiology is all about. And the idea is, you're connecting all this information because you want to keep the people healthy, and those who have health problems or those who have diseases, you want to try to come up with population-based interventions so that you will improve the general health of the population. That's the general idea. The next few chapters, usually in a very general textbook, would talk about, well, it might talk about the history of epidemiology, but, one section of those textbooks would zero in on diseases. Right now, it's, a lot of things are zeroing in on specific diseases to the detriment of other important health-related states or events. And like you've heard from our public health and community medicine people, it's not a very good situation right now. It's like, as you've heard from our public health and community medicine people, or the more community inclined clinicians, right now we're overly focused on the medically defined disease states, or what doctors consider as important diseases. We tend to forget that there are other just as important or maybe even more important health-related issues or problems that affect the general well-being or health of the population. Anyway, so in this section, let's focus on diseases. Well, the first thing that you'll encounter are approaches to causation. Like if you're going to intervene, and you want to try to prevent stuff, then you try to figure out what's causing it. So that's causation. And for those of you who took public health, or even those of you who took medicine, you probably had this lecture about the epidemiologic triad. There's the host and the agent and the environment, and there's the balance between the three. And when these three factors come into play, then the agent can cause the disease on the host. You need an external agent that's going to affect the susceptible host, and the environment sort of brings the host and the agent together, and then suddenly you have a disease. So that's one model of causation. So when we talk about model, these kinds of models, you try to come up with something that you can apply to almost every disease. It's not the clinical approach is, you take specific diseases, like a gazillion of them, and in each one, you try to figure out what the causes are and what are the genetic factors and the specific factors that start the disease. Now, when you're dealing with general approaches that's supposed to work on the majority of diseases, you want concepts or ideas that would apply to several diseases. Some of you during your earlier years, aside from this environment, agent, and host, might have encountered component, causes, and causal pies. Because just by looking at it, when you see host, agent, and the environment, you think, well, it looks like an infectious disease kind of thing. It doesn't feel like it's a non-infectious disease sort of approach. And you're right. And they noticed that it works pretty well for infectious diseases. For non-infectious diseases, well, you can sort of try to make it work, but it doesn't work too well. And so they came up with other things. For one thing, the problem with non-infectious diseases is you can have several causes. You don't need all the causes. You have several causes, and if you have sufficient number of 2 or 3 causes, even if you don't have the other causes, you'll end up with a disease, right? So you'll have a sufficient enough cause for a disease. So all you need is enough number of component causes. You don't need to have all the possible causes. Now, sometimes you might have a necessary cause, meaning you might have all these other component causes, but if you don't have this particular one or two causes, the disease doesn't happen. So that's the necessary kind of element, the necessary cause. So but we won't go there because it's not a lecture for that. So after all these causes, and then imagine if you're armed with that, you go to the community, suddenly you see people who don't have the disease, people who are about to have the disease, people who are actually dying because of the disease, people are actually having the disease right now and you don't know what's going to happen. So you meet people in different stages of the disease, and these host agent environment thing is certainly not enough for you to plan anything or do anything if you're just working with that. Well, we probably come up with preventive measures so that a lot of people don't get the disease, but you also want to help people who have the disease or are about to get the disease. So that's where your natural history of disease comes in. The natural history of the disease is the disease progression if you haven't done anything yet. And that's exactly what you'll find. You enter the community, you're paying attention to this one particular disease, and you see people in various stages. And why do you need that? Because you can plan things out. If they're just susceptible, don't have it yet, maybe you can prevent them from having it. If they already have it, then they can try to figure out how they're getting treated or how you can manage those who already have it. But some of those who already have it don't have symptoms yet. They're subclinical. Some of them are really too far gone. They're dying or they've recovered, but they have disabilities. That's another slew of interventions and other things for public health or community medicine or primary care to do. So that's what it is. That's really what the natural history of disease is all about. So now the disorienting part is being presented in this lecture, and the title of this lecture series for you is the comprehensive approach or the systems approach and the biopsychosocial approach to illness. So how does that work? This natural history of disease came about during the early years of family medicine when the general practitioners decided that they're important and they're here to stay. And even if there are more scientifically inclined clinical fields brewing, it's not enough, and they cannot replace the generalist practitioner, and they wanted to be considered specialists with a generalist mindset. So that's family medicine, and then followed by general medicine and pediatrics. Of course, the question is, how do you become scientific? Well, you have to come up with some conceptual structure to be scientific. Fortunately, during that time, during the 1940s, 1950s, and 1960s, family medicine started during the late 1960s in most developed countries, or became well established. The general systems theory was very, very popular. It's all over the place. It's in engineering. It's even in ecology. There's the ecological system. You have the trees and the different plants and animals, and the ecological system is much more than the sum of its parts. It's even found in machinery. The machine is much more than the sum of its component parts, and you can see what the family medicine people are driving at, pretty much in very simple terms. Of course, they said all sorts of things. Just because you know a lot about the heart or the brain or the psyche, psychiatry and the stomach, the whole person is much more than the sum. Those subspecialist things are much more than the sum of the organs that you're talking about, or the diseases affecting the organs. And the argument is, and therefore, the generalist approach, which we use, is here to stay. It's very important. The other idea behind the systems approach is smaller systems are part of bigger systems, and so on and so forth. And when you open the early books of family medicine, you'll see this in the succeeding lectures. You'll have the cells, and then it becomes organs and organ systems, and then the person, and then the family and the community. They present in each level. The family medicine doctor intervenes in different ways. That's the systems approach. Now, they're just starting out. So the early textbooks were crafted to mirror the systems. So the first part of the book talks about the organs and the diseases affecting the different organs. And then the next part will be the individual, and then the family and the community. That's pretty much how it looked like during the 1970s and then early 1980s. But then the problem is, what do you put in there? They're just starting out and they don't have anything yet. Now, the idea is, well, you look around. It's a very comprehensive approach. The other fields might have something already about it. So that's the reason why you see a lot of stuff coming out of family therapy. I mean, they're not original. Family medicine didn't come up with them. They just borrowed it. And the idea is you borrow it and then you develop it. Of course, they really didn't develop it because by the 1980s and 1990s, they became gatekeepers, and it's more lucrative to just focus on memorizing all the clinical practice guidelines and things like that, which, I don't think is a completely great thing. I mean, we started earning a lot, but then we forgot all about the other biopsychosocial systems approach stuff. But during that time, that's the idea. So that's the reason why when somebody says family, you see stuff coming out of social work about family, or coming out of family counseling and family therapy, all sorts of things put together, try to make sense out of it. Of course, they're not really completely integrated because they're coming from all over the place. When they say community, you see a whole bunch of epidemiology or public health stuff. And this natural history of disease would sound like community much more than it would sound like family or individual. You might see some health psychology going in there, and other things, or you might see the clinical stuff being said when they talk about the individual system. So the question is, what do you present when you talk about the disease? Well, you certainly cannot present the entire book on pathology. And the idea is to present concepts that would apply to most diseases in general, infectious or non-infectious, and things like that. So it's very natural for them to discover, or it made a lot of sense for them to present ideas coming out of public health and epidemiology, because these fields look at diseases in general. And that's what you want out of an introductory chapter on illness and diseases. So that's what it is. But the treatment is different. It's more clinical. So if you have a disease in this stage, how do you approach it clinically? And then it's systems approach. How do you approach it clinically? How do you interact with the individual? How do you interact with the family? What do you do as far as community level is concerned for people in this stage of the disease? So how do you approach the individual, the family? What do you do as far as the medical services and the clinical services and health-related care support services for people already experiencing symptomatic disease, and so on and so forth? That's the general idea. So for a few years, that's pretty much how I did it. Actually, I inherited this has been going on for like decades. So when I came in and I was told to present it, that's pretty much how it sounded. But then the lecture series took on a more biopsychosocial flavor. And the problem with the biopsychosocial flavor is when you look at the natural history of disease, there's the systems thing going on already. I mean, we've been at it for a while. But then the biopsychosocial approach is completely absent. I mean, public health and epidemiology, when they did this natural history of disease, weren't thinking biopsychosocial. So I tweaked it a little bit and modified the presentation. So right now, you'll hear me say, well, if it's in the clinical disease stage and it's symptomatic, it's psycho-emotional impact, it's psychosocial impact on the individual and the family, or even groups of people, will be different compared to when it's already in its latter stages, like, it's approaching death. So I try to make comments on the stage in relation to the psychosocial impact on the individual or the family or in groups of people, or maybe in the community. And so that's how I did it. I'm saying this because when you go to internet and start looking around for natural history of disease, you'll be definitely surprised, because you'll see epidemiology and public health, and you don't see the systems approach in family medicine, and you won't see biopsychosocial in most of the texts. And that's the reason why, because it got borrowed from a field that's not really thinking about the biopsychosocial part. It's meant for something else. Okay.